Bunch of nerds. Just kidding. I knew it was Pi Day as well. What happens if you hook an EKG up to a pi? You get a QT pi. That was not very good. Anyway. Okay, so we're talking about medications for type 2 diabetes. We were talking about our sulfonylureas. We talked about our biguanides like metformin. We talked about all those good options. Another hormone that's important for type 2 diabetics is going to be incretin, or things that mimic the effects of incretin in the body. So basically, this is a set of hormones, and you'll find that glucagon-like peptide 1, or GLP-1, is going to be the most important incretin we're going to be focusing on today. And so essentially what you're finding here in this, this graph, if you're looking at, say, plasma glucose, these are people we're either giving an oral glucose challenge to or an IV glucose dose to. And what you see here is that, as you might expect, between the two, the blood glucose levels were pretty much identical, whether or not you got it orally or whether you got the IV glucose there, right? So nothing really changed between those two. However, the one thing that does change is when you have oral administration of glucose, such as when you intake food, you notice here that this incretin hormone, this GLP-1, has a pretty significant bump in levels. If you were to just give IV dextrose, you actually find that it really has no effect on that, or minimal effect if you were just to receive IV dextrose. And again, most of our patients, how are they getting their carbohydrates? Via the oral route, right? Most likely, unless they're on TPN or something like that. But for the most part, they're going to be getting their stuff orally. So incretin, we know, is an important hormone that's going to be stimulated whenever you have this intake of carbohydrates. And so as I mentioned, GLP-1, or glucagon-like peptide 1, is the most common one we're going to be looking at here. And you'll see that the levels will boost up after mealtime glucose. And also you're going to find that some of the intestinal cells will secrete this. You also have some, you'll actually find that this will actually increase secretion of insulin from the pancreas. So as GLP-1 rises, it will cause more insulin release from the pancreas. So what do you think it does to blood sugar? More insulin means blood sugar should go down, right? It makes sense. Also, another interesting thing is that it actually helps to decrease gastric emptying. It actually decreases food intake. This can actually help to stimulate some of the satiety centers in the brain, and it actually helps you to actually eat less food. Especially if you have a bunch of food sitting there stuck in the stomach because your gastric emptying is slowed down, you're going to feel more full. You're probably going to intake less food, right? A lot of these patients, we said they're overweight, underweight. Well, some are overweight, probably have bad eating habits, in some cases. And so you're going to find that by doing this, you actually will help them to eat less food. So what do you think is a big side effect from these medications? Weight loss, absolutely. And in fact, some of these are actually being used specifically for weight loss. So this is a big thing to consider here. And so anyway, other things we're going to find is it helps to increase transcription for genes dealing with insulin. So again, overall, they're going to help with insulin sensitivity. And another important enzyme to note here is this dipeptidyl peptidase 4. This is actually what's responsible for breaking down GLP-1. So you're going to find there's kind of two classes of medications that are involved with these incretins. There's things that we can give that mimic the effect of incretins. So we call those incretin mimetics. And there's going to be things that help to block the breakdown of GLP-1. So those are going to be DPP-4 inhibitors. Okay, there's two classes there. So, and again, this gives you kind of a good idea of what GLP-1 is going to be doing in the body here. So again, it's going to promote satiety. So again, it's going to reduce appetite for the patient. Hopefully, caloric intake is going to go down. And again, less sugar coming into the GI tract means less sugar to get into the bloodstream. So that can be useful. You're going to find less glucagon secretion, less hepatic production of glucose from the liver due to less glucagon, and it's going to help with that gastric emptying there. And then more insulin secretion. So overall, you're going to find that if we can mimic this system or try to monkey with it, it's going to be able to have pretty good effects on glucose control overall. Okay, so what you find is that just like we saw with a type 2 diabetic patient, what did you notice about, say they have a mealtime intake of carbohydrates, what happened to their glucagon levels? Did they go down like they normally should? No, they're going to stay high for a long time. What happened to their insulin levels? They stayed high for a long time, because we ended up seeing that they were not able to regulate that blood sugar very well because they're so resistant to it. Well, what you end up finding with type 2 diabetics here is you're going to find that they will have less postprandial GLP-1 secretion. So actually have lesser secretion of GLP-1. So you're going to see things like less insulin released in the pancreas. You're going to see less satiety being activated by that over time. And you're going to see more glucagon production. More glucagon means more glucose being produced in the liver, means blood sugars are going to go up here. Okay. And so what we're going to find is by trying to supplement the system, either by helping to prevent the breakdown of GLP-1 or by supplementing it, you're going to find that we're able to help kind of re-regulate the system and hopefully help to kind of improve glycemic control for these patients. And again, what do you think is going to be more beneficial? Trying to prevent the breakdown of GLP-1 in these patients, or actually supplementing it with an exogenous form? Because look at this right here. Type 2 diabetic patients have diminished levels of GLP-1 secretion. So it's probably going to be that if we can give them extra, just like insulin is going to be a lot easier for causing glycemic control than giving them a sulfonylurea. It's much more potent. Same thing here. If we can give an incretin mimetic, it's going to help to replace what they're not producing. You're going to find it's going to be much more useful for helping to control weight, control the glycemic control, etc. So anyway, so looking at this, as we mentioned, again, insulin levels can help to be reestablished like normal levels with the help of incretin mimetics. We're going to find that glucagon suppression should be going down too. So again, this is trying to help reestablish normal control. These patients have kind of lost over a long period of time. Again, looking at GLP-1, it's going to be impaired to patients with type 2 diabetes. That yellow line is going to be normal glucose tolerance versus type 2 diabetics. You're going to notice here the levels are going to be pretty low in comparison. So by, again, supplementing, by giving exogenous forms, it's going to be more potent than necessarily trying to help prevent the breakdown of what they're already producing themselves. Because, again, they're just not producing as much as, say, the patient with normal glucose tolerance. So, anyone know what this is? It's a Gila monster. Why do I put a Gila monster? I think the G is silent, right? Am I saying that right? We use part of it to help produce our drugs. Interestingly enough, we actually use the spit from the Gila monster. And again, who is the scientist that actually figured this out? I have no idea, but good on them, because they figured out something very important. And so we actually find that the saliva from the Gila monster has a lot of homology with GLP-1. So we actually developed this drug called Exenatide, or Byetta. This is the first incretin mimetic we had. It's a protein-based product that looks a lot like GLP-1, has very similar actions in our bodies. And so what do you, just based off of that, what do you think about as far as like what dosage form is it going to take? It's a protein, so going to be injectable, right? So it's going to be an injectable product already. So this whole class here is going to be injectables. What do you think about possible side effects? Unless your patient's a Gila monster, what could happen? They could have anaphylaxis, right? Because again, it's a foreign protein. Anytime you're injecting foreign protein, anaphylaxis is always going to be a risk here. Again, if you have a Gila monster as a patient, like you probably went to the wrong school, right? But anyway, so the indications for this, and again, this is kind of the first one that came out, we're using it as an adjunct. We're using it in addition to things like metformin, insulin sensitizers, in order to help get additional glycemic control for these patients who are not managed on their own. What do you think this does for the cost? It's going to be pretty expensive, pretty cheap. It's going to be expensive, right? These are all protein-based products. These are going to be expensive as compared to metformin, which has been, it's older than dirt, it's been around, costs pennies for a pill versus, you know, something like this is going to cost many thousands of dollars potentially. Okay. You can see here, this one's injected twice daily. If you have someone who's like an insulin-dependent diabetic patient, you're having to add this on board. Like this can cause a big problem with compliance as far as that goes. We're going to see that since this was the first one, you have to give it more frequently. Some of the newer products are going to give less frequently, so that does help compliance quite a bit. And basically, they have the pre-filled pen injectors. They would just inject it just like a normal insulin pen would be injected there. So, again, what you find was that when you give Exenatide, you're going to be causing much better insulin response than you would normally see in a patient that would have kind of poor response in the first place due to diabetes. And so again, here we're giving IV glucose for these patients. You see the yellow line here is going to be the insulin secretion when they were receiving the drug versus just getting placebo, right? So you can see here a very stark difference there in the insulin secretion just due to the addition of this GLP-1 agonist, okay? So adverse effects you might find, due to the fact that we are decreasing the gastric emptying, where's that food more likely to go to? It's not going out, it's going to go up potentially, right? So you can see nausea, vomiting associated with this, right? That does get better with time though, so that's something that's going to be mitigated. Normally these are not going to cause a lot of hypoglycemia. However, if you're mixing it on top of something that does induce insulin release, you may find it's going to be worsened. So hypoglycemia may be a bigger risk if you were to combine this with something like a sulfonylurea. Probably not as big of a risk if you mixed it with something like metformin, because again, metformin does not cause insulin secretion on its own, okay? May delay absorption of other medications. based off of slowing down gastric emptying. You're certainly going to see some weight loss, which is probably not a bad side effect for a lot of these patients, but it could be a concern if they're already kind of skinny to begin with. And then you also run the risk for pancreatitis. Okay, so this is a big one to note with this group of drugs here that can cause pancreatitis. Anything directly stimulating the pancreas, specifically to increase release of things like insulin, can cause pancreatitis, right? So a couple other new ones that have come out, things like liraglutide, we have dulaglutide, and then albiglutide. These are nice because we can administer, say, sub-Q once weekly. Very handy from that standpoint, right? Instead of having to do it twice a day. So Exenatide's kind of gone by the wayside a little bit, but by using something with a longer half-life, it allows for longer duration of actions, allows for less frequent dosing. Okay, better from a compliance standpoint. I actually had an uncle. Is anyone familiar with the actor Wilford Brimley? You have diabetes, right? Yeah, you need testing supplies. You go to Wilford Brimley for his diabetes supplies. Yeah, so he kind of, I think for the young internet generation here, probably popularized diabetes for a lot of us. But I have an uncle that looks just like him. And guess what? He also has diabetes as well. So, however, though, his doctors ended up putting him on Victoza at a point. And so it's interesting because he's not an uncle I see very often, but he's always been a bigger guy, typical metabolic syndrome kind of patient. And sure enough, I went to see him like maybe after a 6-month period or something like that. Go see him, and the dude looks like a shadow of his former self. I'm just like, what happened? Like, completely just lost a ton. I think he lost like 80 pounds or something. And he's like, yeah, I'm just never hungry. I was like, what the heck happened to you? He's like, oh, I got put on the Victoza. And I was like, wow, actually really interesting. Like, he just didn't feel hungry, so he didn't intake those calories, and guess what? He lost a ton of weight. However, it could be taken to an extreme, though, because he got to a point where he just really didn't want to eat at all, and he's starting to get a little bit malnourished because he had poor nutrient intake, and so actually had to take him off of it because of that. But, again, just know that these are always going to be a double-edged sword. Some people will put patients on this just for the weight loss purpose. Just know that's an off-label use. It's not wrong. It just means it's not what the FDA originally approved it for. Okay? Just something to think about. Anyway, so on the flip side of that, so there's the incretin mimetics. We have things that can prevent the breakdown of GLP-1 that patients are producing themselves. Now, you would never want to mix these two together. You probably want to do one or the other. The benefit of the DPP-4 inhibitors is that they are probably a little bit cheaper. They're oral products. You don't have to worry about injecting yourself. And just know that they're working to prevent the breakdown of GLP-1 by inhibiting the enzyme, that DPP-4. By inhibiting that, you have more GLP-1 around. We have a couple in this category, including Sitagliptin. Sitagliptin is probably the first one that came out there, Januvia. We have Saxagliptin and Linagliptin. Side effects are going to be a little bit more tolerable than you would see with the injectable products. Maybe a little bit of diarrhea, headache, but pretty well tolerated for the most part. Just know there is something to flag to risk with this as well, including things like Stevens-Johnson's. So of course, we'll look out for skin manifestations, right? And just to give you an idea, you can combine these drugs together to get additional benefit than either one of these alone. So for instance, giving sitagliptin by itself, metformin by itself, by combining the two together, you can find that you get better effects on things like decrease in A1C, right? So just know combination therapy is very common. If you can get away with using a combo pill, that can be very beneficial from a compliance standpoint. However, remember we talked about patents for drugs. How long do patents last? You remember? 20 years, right? So, and again, is that 20 years from the time they get it on the market? It's 20 years from however long they actually started, clinical trials for it. So oftentimes what people will do is they'll take metformin, they'll take other drugs and say, well, let's just put it together, and guess what? We get a brand new patent out of that. Do the trials, make sure it works, and then use it as a shorter turnaround time because you already know both drugs are safe to begin with. And then guess what? You got a new patent, you got to make that money for that much longer, right? So that's why you see a lot of combination products that come out is sometimes due to getting a new patent for that stuff. Anyway, so again, just kind of comparing the two together, a GLP-1 agonist, something like Exenatide or Victoza, any of those, liraglutide, any of those, versus DPP-4 inhibitors. Again, you're going to find that both of them are going to help with insulin secretion. Both will help reduce glucagon. Typically, the weight loss is going to be better with the GLP-1 agonist. You're going to find better effects on satiety, gastric emptying, all that good stuff. It's going to be much more potent here. However, you're going to find the administration is going to be not as great because, again, people don't like to inject themselves if they don't have to. And you may run the risk of having pancreatitis with these versus Stevens-Johnson's for the DPP-4 inhibitors. Okay, so again, just kind of good comparison between the two groups there. Kind of understand how they work differently than one another. Again, we don't put them together. We use either one or the other for the most part. Okay, and then the newest group of drugs here that fit in the anti-diabetic category are the sodium glucose cotransporter 2 inhibitors, or the SGLT2 inhibitors. So if you remember all the way back when we talked about the kidneys back in physiology, remember what gets filtered at the glomerulus? A lot of stuff, amino acids, glucose, bicarb, electrolytes, everything gets filtered at the glomerulus for the most part. Those are very big molecules, but the big thing we're focusing here obviously is going to be glucose. Now again, how much glucose is normally found in the urine for patients without diabetes? You really shouldn't find any, right? Because remember, they should be able to reabsorb the majority, almost all of that glucose back into the renal tubules, so that way whatever gets filtered gets reabsorbed and none of it should come out in the urine. This is going to blunt that process. It's going to block those transporters, so that way you're going to find that instead of reabsorbing, it's just going to stay in the urine and it's going to go right back out. Okay. So based off of that, what do you think could be some of the side effects of the medication? So if I'm losing all that glucose, losing all those calories, right? What could that lead to? It could lead to weight loss, right? Because again, if you're just eliminating that all the glucose molecules, that doesn't turn into fat later on, right? So again, there's weight you could be losing there. What else do you think could happen if you have all that extra sugar kind of hanging out in the urinary tract? Infections, yeah, actually infection is going to be one of the big things you really need to worry about with this one. And again, not just bacteria, but you have to worry about fungus. And actually, there's been some cases, there's an FDA warning that came out last year about 40 years gangrene actually developing in these patients here. So again, probably not something I want to jump to first line for these patients, but they're having a hard time getting their weight under control, having a hard time getting their blood sugars under control. These may be a good option here. So the three that fit into this category include canagliflozin. Again, whoever's deciding these names, they're just trying to make it more difficult for us, right? There's dapagliflozin and then empagliflozin. Sounds like it's a Scandinavian drug or something. But there's Invokana, Farxiga, and Jardiance. Again, the names just don't really work for this category here. Anyway, but what they're doing is they're inhibiting the SGLT2 protein. That's inhibiting the transport of glucose back into the through the renal tubules, so it all stays in the urine and gets eliminated right through there. So, and again, if you did a UA on these patients, and you saw a ton of glucose there, that makes sense based off the medication list, right? So you can look back on the history and link that back and say, okay, that makes sense there. And again, you find urinary tract fungal infection, 7 to 11%. So again, almost 1 in 10 patients you're going to treat with this can develop a fungal UTI. Not great, right? You see some hypotension with this because, again, not only will they be losing some glucose, but some sodium and whatnot, and fluid's going to be lost along with that. It has kind of a mild diuresis sort of effect. You're aware of that. And then also, interestingly enough, with canagliflozin, they see that there's a increased risk for bone resorption, actual bone fracture risk. This may actually not be a great set of drugs for patients who have osteoporosis. They may have worsened effects there and may make some of their things like bisphosphonates or calcium and vitamin D work a little less better. And then also they could have a risk for something, they could develop diabetic ketoacidosis, although it's a euglycemic ketoacidosis. What do you think is euglycemic? It's not hypoglycemic, but euglycemic. It's not meglycemic. Because again, you're just peeing out all that extra sugar, right? So again, even though the blood sugars may look normal, they could still be in a state of ketosis, because again, they're just peeing out all that sugar there, right? So again, just something to think about, okay? Okay, so this is a really good table. It looks kind of busy, but I think you're a good walkthrough on type 2 diabetic patients and how to manage their medications here. And so basically kind of say, okay, what's the initial first-line therapy you're going to go with? You would say metformin, right? Who would not be a good candidate for metformin? Renal failure, right? And can go into surgery, not a good option for them. But they have hepatic impairment, right? Because what's the main deadly side effect with metformin? Lactic acidosis, right? You got to really be careful with that. So you do not want to cause lactic acidosis for those patients. Now again, why do we like this as a first-line agent? What does it do to the weight? Does it increase it? If anything, it has neutral to decreasing effects, right? So that's good for those patients there. What's the risk for causing hypoglycemia? It's almost zero, right? Because again, it doesn't actually directly stimulate insulin release in the pancreas. So very minimal hypoglycemia risk. What do you think the cost is? Pretty low. So because of that, we like the profile of this. It's low cost. Side effects we know what to avoid for some of those patients there. We know there's low risk for hypoglycemia. We know it's low risk for weight gain, maybe some weight loss. that's why I like it as a first line drug. Now the question is, well, what do you do after that? Like, what can I add on to this? And so really, it's a dealer's choice, right? So whatever you want to add on to this next point. There's not one good option that says, well, this is going to work this much better than these other ones. They all work pretty well. It just depends on different profile characteristics. So for instance, if we had a sulfonylurea, it's a SU here, risk of hypoglycemia, it's probably going to be pretty high, right? That makes sense because it directly stimulates insulin release from the pancreas. Okay, that makes sense. What do you think it's going to do? What do you think about the risk for weight gain? It's going to be pretty high because what does insulin do? Stimulates uptake of glucose into the cells, stimulates fat production, right? And again, it stimulates storage, all that stuff, the glycogen production, stimulates the anabolic hormone, right? It's going to cause weight gain. Anything that's increasing insulin release directly, or you're supplementing insulin, it's always going to cause weight gain, right? You just know that's going to happen. You get low cost, but again, you have to worry about the hypoglycemia risk. So again, kind of compare and contrast all of these to kind of get an idea for who might be a good candidate for one drug versus another. Because again, this is a good test bed for questions I could ask you to say, like, okay, well, I got this patient on metformin, here's a renal function, here's comorbid conditions, what do you think is going to be the next best drug for these patients? And so that'd be a good thing to be able to key in on, right? Patients known for having recurrent hypoglycemia, what's a drug to be contraindicated? Probably say sulfonylureas, right? So little things like that. Try to key in on these points here. And then if you need triple therapy, you can always consider adding on something like insulin's always a good option for these patients. You can always consider adding on something like one of the GLP-1 agonists. So again, it's always a stepwise approach. Always see how they're responding to it. If I said I had patients on metformin, they're still pretty overweight, what would be a good option for them? What causes the most weight loss? The Victoza, like the GLP-1 agonist, right? So again, that might be a good option. A patient was still morbidly obese, on metformin, blood sugar's not under control, and GLP-1 agonist could be a really good option for them. However, what's the drawback of a GLP-1 agonist? They have to inject themselves, and it's really expensive. Okay, so again, those are little key points to hone in on. And ultimately, what can you always put a patient, a diabetic patient, on to get their blood sugar under control? Insulin, right? Insulin's always the final stop for these patients here. Hopefully, you can hold them off from getting to that point, but unless they get the diet and the exercise under control, unless they get their glycemic control fixed, then insulin's always going to be the option there. Okay. Now, when you put a patient who's a type 2 diabetic on insulin, what kind of regimen do you think you put them on first? They do like a sub-Q pump. What I want to do, long-acting with 3 times daily mealtime replacements. What do I want to do? You could do short-acting with meals. It's already 3 injections a day. What can I do instead? Yeah, probably actually end up going long-acting 1 time a day. It's probably the most common thing to start out with. Again, you can eventually build them up to maybe needing mealtime replacements. They might be like on a sliding scale where they'll check it around mealtime, see how high they are. If they need some additional insulin, that's okay. But normally, just 1 time, either Lantus or Levemir or something like that in the morning time, kind of carry them throughout the day. Again, when they're eating, so they're more likely to be hyperglycemic. That's usually what you're going to start these patients out on. Okay. Very good. Any questions on diabetes? Nope. All right, moving on. Let's talk about some other miscellaneous endocrine questions here. So hyperprolactinemia. Anyone know what we do with this? Anyone remember what drugs cause hyperprolactinemia? What did you say? Okay, so you know that you give them dopamine agonists to fix the prolactin level. So in theory, what drugs would cause hyperprolactinemia? Dopamine antagonists. Oh, you guys are making me so proud. What are a group of drugs that are dopamine antagonists? Antipsychotics, absolutely right. So again, anytime you give an antipsychotic, you think about the prolactin effects, think about the gynecomastia in men, think about the amenorrhea in women, all those kinds of things, right? Good. So again, what would be a good dopamine agonist we can administer? Yeah, bromocriptine is probably the most common one to think about there. Again, this is just a straight dopamine agonist. We've seen this before being used in things like Parkinson's before. So again, all the side effects still hold true here. Certainly can see issues with orthostatic hypotension, dizziness, etc. Those are all things to consider. There's another one called cabergoline you can use occasionally. Just be aware of monitoring the blood pressure. Make sure it doesn't get either too high or too low for these patients. Again, the orthostatic hypotensive effects are probably the most prominent things you end up seeing with that. Okay. So moving on, finally get to talk about the guys a little bit. I'm talking about OB-GYN stuff. Spent a lot of time Unfortunately, though, we got a lot less slides for the guys than we do for the ladies. Sorry about that, just the way it is. Actually, in urology section, I think I do later on. We'll talk more about the gentleman there. But let's talk about androgens. And again, females make androgens too, so it's not just a pure black or white kind of issue here. All right. Where do we get our androgens from? We actually can get it from some of our early precursors of things like cholesterol. Certainly progesterone can help with this. And eventually we get testosterone, right? Now, is testosterone the most potent androgen we have? No, what else is more potent? DHT stands for dihydrotestosterone, right? So there's DHT, which is a more potent androgen. And then eventually, what does testosterone can eventually turn into? Based off this slide. Estradiol. Remember when we gave something like an aromatase inhibitor to female patients and we blocked all production of estrogens? What are some of the side effects you saw there? You saw some of the masculinizing effects, right? You saw some of the hirsutism, you saw maybe the acne, you saw deepening of the voice, things like that, because again, you're increasing the testosterone they have because they can't convert it over into something like estradiol there, right? Now, testosterone is the most important androgen made there in the testes, and again, we produce probably about 8 milligrams daily. Obviously, it can depend on a multitude of different factors there for those patients. And most of that is going to get turned into that dihydrotestosterone. And the enzyme that does that is called 5-alpha reductase. Okay, this is the major active component here. And so when we get into talking about urology issues, where do you think the most important urologic condition dealing with androgens is? That's going to be BPH, right? Benign prostatic hypertrophy. So the prostate in guys is going to be very responsive to the effects of androgens. Usually it's going to be stimulatory. If you have a lot of DHT production around, it's going to stimulate the prostate to get much bigger. And what does that do to urination? Because what does the prostate surround? The urethra, right? So against that little chestnut-shaped organ around the urethra, then if it gets bigger and bigger and bigger and bigger, it's going to impinge on that, and that's what causes BPH, right? And so one of the big things we can do to treat that is actually blocking the effects of 5-alpha reductase, and you decrease the amount of DHT you have around. Okay, so kind of keep in mind some of the effects here and how we're going to be affecting this. Also note here, if you had an aromatase inhibitor, that would help prevent some of that testosterone from being turned into estradiol. That's another step here that can occur. And then also note, and this is important for some of the side effects we're going to look at, and also the dosage forms that we use here, is that the androgens get metabolized in the liver. Okay, similar to what we saw with estrogens, and normally that had an effect on things like clotting factors. Just keep in mind that the androgens are metabolized in the liver here as well. Okay, and again, how do all these hormones work? How do steroids work? They go to the nucleus, and they change the gene transcription factors, right? So depending on what tissue you're in, will determine what type of factors is involved with, and will determine what kind of effects you're going to see there, right? So for instance, if I were to apply testosterone, say, to the skeletal muscle, what do you see? See hypertrophy, right? It stimulates muscle growth, right? So we see like puberty or something, see the muscles get bigger when you have that exposure to that increased testosterone and DHT. And again, this undergoes the same process as you see with the estrogen and progesterone production in female patients here. Obviously, it's a little bit more simple because we don't have to worry about things like the menstrual cycle, but just know that the hypothalamus is releasing GnRH. This is then going to stimulate the pituitary to release LH and FSH, and that eventually will stimulate the testes to produce testosterone. Okay. Now imagine, what if I were to give someone exogenous testosterone, or give them, say, injections of it? What do you think it's going to do to the system here? It's going to do what? Shut it down, right? Absolutely. So again, by negative feedback inhibition, it's going to shut this whole thing down. What do you think it does to the testes? They actually shrink, right? So you get this can't think of the word right now. Atrophy. Thank you, man. It's a long day. Actually, I find that they'll actually atrophy due to the fact that they're not producing their own testosterone anymore, right? So again, that's a big side effect you think about with patients who might be on exogenous androgens there. But yeah, so again, think about that negative feedback loop, what's going to cause that to be shut down there. If you remember, you talked about in OB-GYN a little bit, things like leuprolide and goserelin, things that were GnRH agonists. Remember, initially they can actually cause stimulation, but eventually they can desensitize and cause the whole thing to shut down as well. So sometimes you'll end up seeing patients on that for suppression of some of these hormones. But testosterone is definitely going to have that negative feedback effect there. So again, the naturally occurring forms we have in the human body is going to be testosterone. Just note there's going to be a ton of different formulations that are out there. Normally, how do we give androgens? Anyone know? Go ahead.
Yes, a gel.
A gel? Okay, so a gel applied where? Good. Okay, so we have transdermal absorption. What else? You can do injections, absolutely. You can do intramuscular injections, right? It's how a lot of bodybuilders and stuff are using a lot of exogenous androgens. So you see all those needles, you think, man, there's a lot of diabetics at this gym. The sharp boxes? That's fantastic, right? Because again, rather than use that and then a bunch of dirty needles around, right? So there's that. What other forms do you think we could use? Now you notice, we talked about oral contraceptives. There's a lot of oral estrogen products. How come there's not a lot of oral testosterone products? It's really, really tough on the liver. You cause a lot of hepatic injury by giving oral testosterone. So that's typically why we do not see a lot of that. There's a lot of first pass effect that occurs there, and it can be really rough on the liver. So most typically, you're going to find that testosterone is given either via transdermal dosage forms, like either gel or a patch, or we'll use like an injectable form, like an intramuscular injection. Okay, so that's the most common thing you're going to see with that. And then, as I mentioned, dihydrotestosterone gets produced by converting that over the 5-alpha reductase into testosterone to DHT. Now, we have a lot of different forms that are out there. For instance, we have things like methyltestosterone, fluoxymestrone. These are all PO forms, but again, they're not used quite as often, and because of the fact that they are, again, very hepatotoxic. And most of the time, you're going to find just straight testosterone being administered to these patients here, right? So, looking at this, you're going to find that when you have the effects of the androgens, we know we have an idea about the different effects these have here, but it's going to cause things like development of the internal external genitalia. As we see, like in puberty, it's going to cause increase in skeletal muscle growth, erythropoiesis, right? So this is a component sometimes of blood doping, right? Obviously, what's the more important thing to cause erythropoiesis? Some other hormone. Yeah, EPO, right? So erythropoietin is going to obviously be more important for that, but you can see some erythropoiesis stimulated with androgens here. And just know that when you have that conversion of testosterone over into estrogen, you will see some effects, and again, it's due to that aromatase enzyme, so it could have effects on libido, cause on bone, the growth plate closure, things like that. So, what are some places where we'd want to use androgens? What are some therapeutic effects or therapeutic cases where we'd want to use it? Because recreationally, people can abuse it, right? For what purposes? To get swole. Thank you. They don't get shredded, right? But they get swole. What do you use to get shredded? Razor blades? Hydroxy cut. Usually stimulants, right? You use a lot of stimulants to help kind of get rid of body fat. Sometimes you can use things like diuretics, right? We use diuretics quite a bit to get rid of some of that water weight. But yeah, so you get swole, right? So you're going to see development of the skeletal muscle. But what are some, like, when would that be an appropriate therapeutic indication, right? You can't come to your doctor and be like, I'd like to be able to bench 4,000 pounds. And they're going to say, I'm not going to give you anything for that. But what could be some therapeutic indications where you have muscle wasting that you do want to help out? Sometimes like cancer patients, sometimes like AIDS patients that have a lot of muscle wasting, you can give them testosterone supplements to try to kind of boost them back up a little bit, right? And give them some combination of things like appetite stimulants to try to get them to try to eat more food, get more calories in order to help kind of put some weight back on. There's some cases like that, right? What effects does testosterone have on the bone? Usually stimulatory, right? So again, it can have, try to stave off osteoporosis in some cases there, right? Especially if that is a primary reason for that patient to be osteoporotic in the first place. And there's a lot of different reasons here. As I mentioned, the offset the weight loss. This is kind of where I would see it a little bit more frequently. Like burns, trauma, etc. That could be a good indication for using that there, right? So again, if you ever see that like on an inpatient, they're not trying to get swole in the hospital. They're just trying to put on muscle that they maybe have lost due to maybe chronic illness or something like that. Okay. Yes. I don't necessarily see it suppress the immune system so much. Probably didn't help it at all, but I don't know that it suppresses it significantly. And then in some cases, we'll talk about anti-androgens. These obviously can be used for things like metastatic prostate cancer, really severe cases. We'll talk about prostate stuff a little bit later on in the urology section. It'll come up next. All right, so again, I mentioned there's several dosage forms. Again, we don't really like the oral forms because they tend to be fairly hepatotoxic, so we don't like them too frequently. That and the bioavailability is not great. They oftentimes will get metabolized pretty quickly there. So injections are the most common, and then transdermal is going to be those are probably 1 and 2 there as far as how often you're going to see that being given there. Okay. Again, these are just the different salt forms it's going to be in. Typically, the injectable forms are going to be in an oil base. Why do you think we do that? Yeah, it stays there for longer, right? Because oil typically doesn't mix with the blood too well. So again, it makes it less less hydrophilic. So by doing that, it's going to stay in the muscle for longer, so you get that depot sort of effect, right? So anytime you see something in an oil base, it's typically because it likes to stay there as a depot sort of effect. So for instance, like Depo-Provera, like if you see like the medroxyprogesterone injectable form for birth control, if you see Haldol, long-acting Haldol being given to the muscle, it's usually an oil base because it likes to stay there for longer. Okay. And just a few different anti-androgens you might find. Again, most often these are going to be used for things like prostate cancer, things like flutamide, bicalutamide. These are actually going to be the androgen receptor antagonists. If you also remember, we talked about as far as diuretics go, remember spironolactone has some mixed androgen receptor effects here as well, right? So what effects did it have, say, for instance, in male patients? Gynecomastia is a big one, right? What does it do in female patients? Why is it called hirsutism, though? Because it's hirsutism, not his-sutism. No, because remember, it's a partial agonist, right? So again, for females who maybe have a relatively low testosterone effect, you actually end up seeing increased androgen effects. For guys, though, who have a higher testosterone level, you see decreased androgen effects, right? Because it's going to be interacting with that receptor. It doesn't activate it fully, but it will have some partial effects there. Okay, so kind of keep that in mind. And we'll talk about the 5-alpha reductase inhibitors a little bit later on, but that's basically blocking conversion of testosterone to DHT. Finasteride and dutasteride are going to be the two that fit into that category. We'll talk about that a little bit later. And again, side effects are always something to consider. Again, it's going to make BPH worse. It's going to make the prostate grow in size. It can lead to prostate cancer in some cases. You certainly can see a infertility occur here. Actually, I was watching. There's a good documentary on Netflix at the time. It was about a guy and his family, and they used a lot of anabolic steroids. They're talking about how when one of his brothers wanted to get pregnant, he had to actually go off steroids, trying to make sure he actually get back to where he's producing his own testosterone again, so he'd be able to develop sperm appropriately. And then as soon as he had the kid, then he went right back on it. Right. So sometimes you'll see them kind of cycle through that stuff. Yes, that is the movie. Thank you. Very good documentary, I think. Yes, sir.
Earlier said that one of the uses was for infertility, then it can cause.
Exactly, right? So again, it's one of those cases where it's a double-edged sword here. If I kind of gently stimulate, if it's someone who doesn't have much testosterone activity at all themselves, so say for instance they have a pituitary issue or they're not producing the LH and FSH, you maybe stimulate that with the testosterone. But if I have someone who's normally producing everything appropriately, by giving that testosterone, it's going to shut down the whole system, and that is going to decrease the effects of LH and FSH on sperm production. Okay, again, you're going to see some increased salt and water retention, so that could be bad for CHF patients. Be aware of that. And again, be very careful with the hepatic effects. This is very common. You're going to see hepatitis develop with this. You can see cholestasis occur with this. So again, that's why we don't like the oral dosage forms there. And of course, women are taking it. They can't see masculinization of effects. So you can see deep into the voice, hirsutism, etc. Okay. Now, when we have a female patient who's taking testosterone, yeah, think about transgender patients, right? So again, it could be something that is now being done more and more frequently, so you may see that occasionally, depending on what kind of patient population you're dealing with. But it's one of those things where you don't want to necessarily be like, well, why in the heck would I ever, as a pharmacist, I think, well, why would I ever feel that? Well, there's a decent indication for it, right? But again, sometimes you will see female patients abusing it, again, from like a bodybuilding perspective, so you see that occasionally. But again, we'll talk about BPH later on and how we manage that. But mainly for the most part, we're blocking DHT. It's going to be the best way to help kind of decrease DHT effects on that. It's going to help to kind of shrink down the prostate. We'll talk about that more later. And then I mentioned the GnRH analogs. Again, these can sometimes be used to, in low doses, kind of stimulate production of testosterone in some patients who may not have that good stimulation on their own. More often than not, that we're going to be using this to kind of shut down the entire system by overstimulating, just like we do in female patients potentially. That's like Gozerelin and Leuprolide are the two big ones there. So again, you can see here on this chart how different places or different drugs can kind of come in and interrupt the system here. So for instance, the GnRH antagonist is going to sit here and block this from stimulating the pituitary. You'll see something like finasteride coming here blocking 5-alpha reductase. So again, just kind of give you a pictorial example where these different drugs will come into play. Okay, so let's do a 10-minute break now. We'll come back, finish out the section, and move on to nephrology. Okay, doesn't matter if you're ready or not. Here we go. All right, so moving on, talking about corticosteroids, right? So what's the main corticosteroid you guys all produce? Cortisol, right? Some of you are probably experiencing quite a bit of it right now, right? So stress ulcer nursing right now. It's all the increased glucose levels you're experiencing, also from stress eating, so you guys probably have a lot of cortisol effects around. Probably get sick more often. Probably I'm getting sick more often, right? So we know the glucocorticoid effects, right? When I say mineralocorticoid effects, what do I mean? All right, so you think about aldosterone, what does that mean though? What does it do? Think about minerals, you think minerals, you think sodium, you think water balance, right? You think about water balance, because typically aldosterone is going to do what for us? It's going to allow for more reabsorption of water and salt, and so by doing that, what does it do to our intravascular volume? It goes up. What does that do to our blood pressure? It goes up, right? So if you have, say, someone who had the inability to produce aldosterone, they would lose a lot of salt and water, and their blood pressure would be low, right? So this is an important thing to consider, right? Think about the mineralocorticoid effects. And typically when you're looking at steroids, and you were thinking about typical glucocorticoids, you're going to find that some have a little bit more heavily focused on the glucocorticoid effects, like immunosuppression, hyperglycemia, etc. Some are a little bit more focused on the mineralocorticoid effects, like hydrocortisone, fludrocortisone, a few of those we're going to talk about today. So it's important to kind of keep those distinct in your mind. But again, aldosterone is a kind of prototypical sort of mineralocorticoid we mostly think about. Now remember, it helps us to hold on to sodium and water. What does it get rid of as a result of that? Potassium, right? Remember, they can become hypokalemic because of that. Again, cortisol, which is, again, is just another name for hydrocortisone, right? So again, it's the same product essentially that we're producing there. Normally, we're going to be secreting, say, 10 to 20 milligrams daily. You're going to find that can vary greatly depending on the time of day. Also, we know that when you're in a stress state, your levels are actually going to increase. And I used to always joke, I was like, yeah, it'd be really funny to do a study where you looked at cortisol levels when you guys came into school versus like maybe at like the peak of all the testing, and then maybe we'd go on rotations to see how much it drops. And actually, someone actually took that, and so a group of my Adventist students are actually doing that as part of their grad project. So actually testing on the class behind them the levels of cortisol. So I'm interested to see how that's going to go. But anyway, so again, sometimes the jokes I say turn into real things, and then I really worry about what I actually say, what you guys are taking away from that. But that was a good one. So again, if you think about like insufficiency, right? So you have chronic insufficiency, you have Addison's disease, and it makes sense a lot of the things you find. You see the weakness, you see the hypotension. They can't really regulate their glucose very well, right? Because again, they don't have that glucocorticoid effects there. And in some cases, especially when they undergo a lot of like extreme, say, emotional or physiologic stress, they can develop circulatory shock, and they can die from that. And so very frequently what we end up doing is we'll give them stress dose hormones. And so say for instance, I have one patient who comes in pretty frequently who had a tumor basically in the brain. They had part of it resected, and now they are basically put in this kind of chronic Addison sort of state here where they're not producing enough of their own cortisol. And so not only do they have to take a normal dose of hydrocortisone every single day, but sometimes when they know they're getting sick or they're getting stressed, they'll take additional cortisol on top of that to try to mimic what the glands would be producing on their own. So by doing that, they can try to regulate that and hopefully not end up in the hospital. Unfortunately, they end up in the hospital anyway, and they're usually very hypotensive, hypoglycemic, and so we have to kind of supplement by giving additional hormones in order to kind of replace what they're missing essentially. One of the other big ones we'll give them is also fludrocortisone. This one has pure mineralocorticoid effects. This is as close to aldosterone as you can actually get, since we can't give synthetic aldosterone, we give fludrocortisone instead. And so because it's such strong salt-retaining sort of effects, it's very good for getting blood pressure back up. And in fact, sometimes what you find, if you say you're dealing with like a critical care patient, and say they're coming in for sepsis, and they're really physiologically stressed, and say they're hypotensive, and so you're giving them epinephrine, you're giving them dopamine, norepinephrine, and you still can't get their blood pressure under control. One of the things you can actually do is give them stress dose hormones. You can give them hydrocortisone for the mineralocorticoid effects, because usually when you have a septic patient like that, the vessels get very leaky, so they're losing a lot of fluid into interstitial space. By giving them hydrocortisone, you actually help them to hold on to more of that, and that helps to tank up the intravascular space and allows that pressure to come up. Sometimes you actually get them off a few of those vasopressors there. So little things to think about when you need that extra mineralocorticoid effect, when you can supplement with that, kind of what kind of different conditions you can try to treat that with. Okay, moving into thyroid pharmacology. So a little bit more information to do with this. What's the main thing we're going to be using to help replace the thyroid hormone? What do we give? Levothyroxine, otherwise known as Synthroid. That's going to be the most common one we're going to talk about today. But know that we can have either hypo or hyper secretion of thyroid hormone. Obviously, we can find that it can be at any level. It could be at the level of the thyroid, it could be a level at the pituitary, it could be the level of hypothalamus, could be anywhere in between. And so again, regardless, if we find hyposecretion, how are we going to treat that? We're just going to give them more thyroxine, right? We're going to give them more replacement of that. How about hypersecretion? What can we do? Anyone else? We can get rid of the thyroid gland altogether. We can just cut the whole thing out. Could do that. What else could we do? Well, what are the main forms of thyroid hormone that are out there? There's T3 and T4. Remember, which one's more active? T3 is more active, right? So I can do things like try to prevent the conversion from one over to the other. We can try to prevent the production of thyroid hormone, the actual thyroid itself. There's lots of different ways we can do that, right? So we'll talk about the different drugs here, but it's important to understand the process and how thyroid hormone is actually produced in the first place. So normally you're going to find you have the hypothalamus here. It's going to be secreting. What's it going to secrete? The THRH, right, thyrotropin releasing hormone, and so you're going to be, TRH is going to be released onto the anterior pituitary, that then releases TSH, right, so thyroid stimulating hormone. It's going to directly stimulate the thyroid, and then that should cause a negative feedback loop to occur here, right? So what are some things that can interrupt this process here? Maybe you can't produce enough thyroid hormone in the thyroid itself. Yeah, no iodine could be an important thing there. So that's one mineral we haven't really talked about too much so far, but you need that. Or it could be if you don't have enough TSH potentially, right? Maybe you have a pituitary tumor that had to get resected. They can't produce it on their own. Lots of different reasons for that, right? Ultimately, we can always give a thyroxine in order to help try to replace that if we need to. Now, if you notice here, you see iodine here. Notice here it can either have a positive or a negative effect here, okay? So in patients who say have a deficiency of iodine in their diet, you're going to find they are going to be deficient, and they're not going to be able to produce enough T3 and T4 on their own. However, you can also overblow it and actually give them way too much thyroid hormone, or give them too much iodine, and that can actually shut down the production of thyroid hormone as well. Okay, and in fact, if there was ever a, say for instance, there's like a nuclear attack that occurred here, and say you survived the blast, then we'll know what supplement you should take. You should give iodine. Why should you take iodine? Because what? So what it actually does is, so one of the important, the byproducts of a nuclear blast is actually a radioactive form of iodine. And so if you start to uptake that into yourself, if you were to say you were to ingest it or to breathe it in, that's going to get taken up into your thyroid gland. And guess what? All that nice irradiated, that radioactive iodine is going to then kill off your thyroid gland. That's actually one way you can actually get rid of the thyroid gland itself, by giving radioactive iodine. So what you can do is by taking a whole bunch of it, you can try to replete the thyroid with a bunch of iodine and prevent the uptake of the radioactive stuff. You can just eliminate it normally. So if you're ever caught in a nuclear blast, which I hope none of you ever are, you should take iodine supplements to try to keep your thyroid healthy.
Or if not, just carry a bottle of Synthroid.
Or you can carry a bottle of Synthroid with you potentially, but I don't know, I think the iodines might be a little bit more effective. You have multiple uses for iodine, right? You could use topical iodine as a cleanser. You could also use it to help absorb some of that. So lots of different reasons why you should, when you have your bug out bag for the eventual nuclear winter that occurs, you should definitely have iodine tablets in there. The reason why I know that is because I imparted that useless knowledge onto you, or potentially very useful. It's either going to be completely not useful at all or extremely useful in one particular circumstance. It's because my pathophys teacher told me this when I was in school. So I said, you know what, I'm going to pass it on, pay it forward, so that way you can't say that no one ever taught you that. Anywho, so the process here, what's actually going to happen to produce T3 and T4 is you're going to find that iodine is going to come in and get turned into iodide. Okay, this is going to then undergo what we call an organification process, where it's going to mix with tyrosine. Right, tyrosine is an organic molecule. By combining these two together, you're going to get monoiodotyrosine and diiodotyrosine. Then you can pop those together and either form T4, or you're going to form T3, or a little bit of it gets turned into, anyone know what it gets turned into? The third way. There's a reverse T3, and reverse T3 doesn't really do much for us. But by doing that, it's going to eventually get formed into T4 or T3, and then it can then be released into the bloodstream. You're going to find that T4, again, as we mentioned, is going to be the less active form. It eventually gets turned into T3, which is going to be able to interact with the nucleus, get in there, change transcription factors to cause all the effects that thyroid hormone normally causes. Okay, temperature regulation, metabolism, fatigue, all that kind of stuff is going to be able to help regulate that. Okay. And this is where we're going to find that some of our medications are going to be useful for helping to block conversion of T4 into T3. Can actually help with things like thyroid storm, which we'll talk about a little bit later. Again, in terms of the iodide trapping is going to be able to occur here. You're going to find that once you get iodide into the cells, is going to get converted. And again, I apologize, I misspoke. I always get this wrong every year. If it's iodide, you're going to take into your diet, that gets converted to iodine. I'm not going to ask you that on a test. Again, I don't really know. Most people probably get that right in the most cases. But anyway, there's peroxidates can convert that over. But then you have this organification process that occurs. It's going to form tyrosine along with that. And so again, if you have two diiodotyrosines pop together, you get T4. If you have a diiodo and a monoiodo together, you get T3. Essentially, so that's kind of the big difference between those. As I mentioned, high levels of iodide will actually prevent this process from occurring, which is why if you have too much iodide in your diet, you're going to find that it has a suppressive effect on the thyroid hormone or thyroid gland. So, as I mentioned, once they get popped together, then you're going to form either T4 or T3. Sometimes you get that reverse T3, which is not going to be all that physiologically active, but for the most part, T4 is going to be made in the biggest proportion there. Okay. And then some of it can be stored within the thyroid gland itself. The rest of it is going to get released out into the bloodstream where it has its effect. You can use the ratio here. T4 to T3 is about 5 to 1. That's only important for some of the medications we'll talk about in just a second to try to mimic that. Again, pictures are showing the same thing here. So as I mentioned, some of the things we can try to do to prevent this from occurring, if we have high levels of iodide, obviously that's going to have a suppressive sort of effect on the thyroid gland. But once it gets released into circulation, you're going to find that T4 is considered to be a pro-hormone, where it's going to get converted over to T3. It has a lot more potent activity at that point there, right? And again, this is also another process that can be inhibited by high levels of iodide. It can be preventing the popping off of one of those from the T4 to turn it into T3 essentially. As I mentioned, that deiodination of T4 can either form regular T3, which is good, or it can form that reverse T3, which is inactive, not useful for our purposes. Here's just a picture kind of showing what this looks like. So again, here's thyroxine, which is T4. Again, some of it will get turned into T3. Some of it will be that reverse T3, and this is actually no good for us. This is the main one we're kind of concerned about. Again, I'm not going to have you draw that on a test or anything. Just know that those are the two byproducts. So, getting into the actual drugs we're going to be supplementing for our patients here, the common one we're going to give is levothyroxine. Now, levothyroxine is actually T4. So what do you think about the duration of action, or the onset of action for this drug? Pretty fast, pretty slow? Pretty slow, right? You're not going to see dramatic effects in activity of thyroid hormone when you give thyroxine. That makes sense because we know it's not the active form. It has to get converted over in the first place. However, this is the most common one. It's pretty cheap. It's available. We've been using it for many, many years there. And again, we don't have a whole lot of issues with it. As far as from therapeutic use, it's okay if it takes a while because again we can manage the patient during that time frame. There are some parenteral formulations. You don't use it too frequently. Most often it's going to be an oral product there, but just be aware of different drug-food interactions. If you're taking iron supplements or calcium supplements, drinking it with milk or something, you can bind that up. And so again, if you're seeing that your TSH levels are just not responding well, it could be related to a dietary interaction. You can see with that. Okay. You can have just pure T3 we could give you, and the onset of action for that one would be faster, slower? Way faster, right? Because we know that T3 is the active form. That makes sense. However, it's a lot higher cost. We actually don't really ever use it. I've never actually seen it being used there, but I'm just know that as an available formulation. And there's one called Lyotrix, which is actually trying to mimic the actual normal formulation of T4 to T3 that we would be producing ourselves. This is an oral product. Some people like it better because it's considered to be kind of a more natural balance of T4 to T3, but very frequently I don't see this being used. And levothyroxine and Synthroids can be far and away the most common one there. Okay. And again, most often it's going to be used for hypothyroidism. You would not want to give this to someone who is hyperthyroid because obviously it's just going to make that worse for those patients there. Okay. Now again, looking at some of these other drugs, when you find that thyroid hormone actually gets into the cell, T4 gets converted over to T3. Once it gets into the nucleus, that's where it's going to have the similar effects to what we see with glucocorticoids or androgens or estrogens. It's going to change gene transcription at the nuclear level, and that's going to have all the normal physiologic effects we'd expect. The thing I also want to talk about is the anti-thyroid drugs, and what you're going to be doing with this. So again, these are either drugs that help to prevent the production of thyroid hormone, or it's going to be things that help to prevent the conversion of T4 over to T3, right? So again, that will help to limit the effects of T3 overall in the body. And the two main drugs we have for preventing production of thyroid hormone is going to be propionthiouracil, or PTU, and you're going to have methimazole or tapazole. You're gonna find either of these are pretty appropriate for most patients, as the case may be. Very well tolerated for the most part, and you're going to find that you may have agranulocytosis very rarely, and it's one thing you want to note. Look for infections, etc., as a result of that. Now, normally what these are going to do is actually interfere with that peroxidase enzyme, and they prevent that conversion from iodide over to iodine. That's one of the main ways that's going to be working there, and also interferes with that organification. So you can't attach the iodide to the tyrosine, so that way you can never form that monoiodo and diiodotyrosine there. Okay. So again, common cases we're going to use include things like Graves' disease, which again we know we're producing the TSH stimulating antibodies are going to generate, or they're going to stimulate that. So you can use this to prevent production of new T4 and T3. Works very well for that. And then sometimes we can actually give radioactive iodine, as I mentioned. This will again get uptaken into the actual thyroid itself and can kind of radio ablate it essentially by releasing radioactive waves there, where it's actually going to ablate the tissue. Sometimes you can use that. Again, obviously we know they're going to cause delayed hypothyroidism. That makes kind of sense because again we're kind of ablating the tissue itself with this stuff. Let me see. And then sometimes you'll actually give a saturated solution of potassium iodide. Sometimes this is given. So if you ever see SSKI, it stands for saturated solution of potassium iodide. Again, potassium being K on the elemental table there. Or Lugol solution is another name known for this. This is actually frequently used to treat hyperthyroidism. By giving a big concentration of iodine, you help to prevent the conversion of T4 to T3. You help prevent production of new T4 and T3. So it's very good from that standpoint there. Also, you can see some, you'll use this prophylactically, especially as I mentioned for patients with that radiation exposure there. Yeah. And then there's a lot of contrast dyes that are used that include iodine in them. So just be aware that there's one here, this Ipodate is used particularly for thyroid storm, or if you have this thyrotoxic crisis. Again, by preventing conversion of T4 to T3, it helps to limit some of the effects of that hormone there. So any questions on endocrine stuff? I know it's kind of fast, but again, it's kind of a potpourri of different things. Don't need to spend a whole lot of time in there. The only time I ever see IV levothyroxine being used is actually in the case, at least personally, whatever I've ever seen it, is in the case of patients who are going to be, they're considered brain dead, or going to be donating their organs for other patients, right? So oftentimes what you'll have is a patient who's declared brain dead. They'll have TransLife come in. TransLife is a company that manages a lot of that. They'll come in and they have a nurse that basically will take over care for that patient. And so basically once the brain is dead at that point, they can't regulate a lot of their normal bodily functions. So we have to regulate things like blood pressure. We have to give them things like thyroid hormone. We have to give them corticosteroids, all kinds of stuff to kind of regulate that. So that's where I see a lot of IV levothyroxine being used. Any questions on that section? All right, so let's move into nephrology. Let's see what I can cover in my short time that I have left.